Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. This is part 2 of our 2-part EM Cases podcast on liver disease for the ED doc with Walter Himmel and Brian Steinhart. In this part 2, we're going to talk about thrombosis and bleeding in liver patients. Very confusing, but we're going to clear it up for you nicely. About spontaneous bacterial peritonitis and some pearls on tapping bellies and a few more little goodies to wrap up with. So we've covered GI bleeds in 2 big episodes. That was number 101 and 102 with Swami and Salim Rezai. So we're not going to get into the details of managing the actual GI bleed here, but there are some nuances when it comes to liver patients and bleeding that I think we need to cover. We've all seen patients that have liver disease and come in with horrible GI bleeds. We also know that liver patients are at increased risk for thrombotic events, for portal vein thrombosis, PE, DVT, etc. And we know that the elevated INR we see in liver patients doesn't necessarily mean they're protected from thrombotic events. This is all very confusing to me. So, Dr. Himmel, I hereby present you a challenge. Good sir, in less than 5 minutes, can you explain to our listeners what's going on in the liver patient when it comes to coagulopathy and hemorrhage?
Absolutely. First of all, liberate yourself from all your misbeliefs completely. And remember the following. Individuals with cirrhosis who are admitted to the hospital get more DVTs than patients who don't have cirrhosis. Patients with cirrhosis, as a common complication, get thrombosis of their portal and splenic vein. So patients with liver disease are often prone to thrombosis. In fact, they're more prone to thrombosis and major bleeding. As far as gastrointestinal bleeding in cirrhotic patients, the major cause is not coagulopathy. The major reason patients with cirrhosis get GI bleeds is portal hypertension. It's a pressure problem, not a bleeding problem. Now, I don't want to overstate it. So first, the INR. If you've been practicing medicine for the last 20 or 30 years, you've been prescribing Coumadin for years, although much less recently. And you're accustomed to knowing that when you give someone Coumadin, the blood gets thin. You measure the INR. INR is up. The blood is thin. They're anticoagulated. They're going to bleed. As a consequence of that, you now may believe if the INR is up, it means the patient is prone to bleeding. Nothing could be further from the truth. When you measure someone's INR, you're measuring basically vitamin K-dependent factors if the patient's healthy and on warfarin. So when you measure the INR and the warfarin, you're measuring 2, 7, 9, and 10, which is decreased, and protein S and C, which is decreased. And if they're decreased, and the patient's healthy and on warfarin, they're prone to bleeding, and that's the end of that story. Now let's get to liver disease. Liver disease has a problem with synthesis, and it is true, patients with liver disease produce less factors 2, 7, 9, and 10. They also produce less factors 1 and 5, and you would think, as a consequence of that, they'd be more prone to bleeding. But it's not that simple. The coagulation system has 2 parts to it. The parts that make you coagulate and the parts that make you uncoagulate. They're balanced. And it is true, people with cirrhosis have a high INR because their factors 1, 2, 7, 9, and 10 are low. However, there's also something called protein S and protein C. Protein S and C are natural anticoagulants. And in liver disease, protein S and C are obviously exceedingly reduced, more than 2, 7, 9, and 10. So because protein S and C, your natural anticoagulants, are inappropriately, excessively reduced, that makes you prone to clotting. And of course, there's a fine balance and it can vary. We also have to talk about some other factors in your blood, because there's way more to life than the factors 1 to 12. There's something called factor 8. Factor 8 is not produced by the hepatocyte. Factor 8 is produced in the endothelium. Factor 8 is a marker of inflammation. If you have liver disease, your factor 8 is often increased, which means you're going to be prone to clotting. If you have liver disease, your von Willebrand's factor, which lives with factor VIII and which lives in endothelium, is going to be increased and going to be prone to clotting. So because of factor VIII being higher, because of von Willebrand's factor being higher, and because S and C are too low, you'll be prone to clotting. And because your 2, 7, 9, and 10 are low, you'll be prone to bleeding. And often the two aren't balanced. So some patients will bleed and some patients will clot. And this is why you see both things. But the overall propensity in liver disease is actually to clot, not to bleed. Now, I want to speak a little bit about a couple of other factors. Antithrombin. You probably heard of antithrombin, antithrombin 3. It's part of your natural anticoagulants that balances the system. And in liver disease, your antithrombin is decreased excessively, which means you're prone to clotting. So why do we bleed? And why do we clot in liver disease? Because it's not a matter of what's too high or too low. It's dysregulated. It's out of balance. Why is INR meaningless in liver disease other than to tell you your liver is screwed up? It's because your 2, 7, 9, and 10 and S and C aren't decreased symmetrically the way they are with warfarin. So INR liver disease, very important. If it's up, you know you've got liver disease. But it does not tell you you're prone to bleeding because it doesn't reflect all the fine points of 1, 2, 5, 7, 9, 10, protein S, protein C. What should you remember? That you're prone to clotting, that you're prone to bleeding, that high INR that's high does not mean you're prone to bleeding, and these patients often need anticoagulants for clotting.
Brilliant. All right. So the key concepts there are, one, that most bleeding complications are actually related to portal hypertension, not to abnormal hemostasis.
Yep.
That, two, a high INR does not mean the patient is protected against thrombosis. And number three, that thrombosis is actually a more common problem for liver patients than bleeding is, even though we tend to remember the bleeding more because we see these massive GI bleeds quite often in the emergency department. And when it does come to bleeding, really the bleeding is because of problems with platelets, the platelet number and platelet function, from increased fibrinolysis, from vitamin K deficiency, and from decreased production of some of these clotting factors. So,
and fragile blood vessels, and trauma, and atherosclerosis. It's an interaction back and forth, and sometimes it swings in one direction, and sometimes in the other direction.
Yeah, the corollary is if your INR is normal, the chances are you have hemostasis capability.
Well, I would say if your INR is normal, you haven't got bad cirrhosis. Thank God.
Correct.
Given this confusing pathophysiology, which you've beautifully made nice and simple for us, thank you, Walter, for these patients with liver disease, how do we then, on a practical level, manage the liver patient with life-threatening bleeding in the ED? So besides all the stuff that we know about how to manage GI bleeds that we talked about in the past episodes, when it comes to actual bleeding, what do we need to do? So there's cryoprecipitate, there's massive transfusion, there's pools of platelets, there's vitamin K, there's TXA. What do we have to know specifically when it comes to liver patients and how to fix their bleeding?
Well, first and foremost, treat local problems locally. Epistaxis is treating locally. Oral bleeding is treated locally. Bleeding from the gut, you have to treat presumptively ulcer, gastritis bleeding, and varices bleeding and get a scope early. So you have to all those things. If you are hemorrhaging to death, you have to give blood. If you're not hemorrhaging to death, you will treat the hemoglobin up to about 70 or 75 and no higher, because we know if you have someone who has an upper GI bleed and they're not exsanguating, and we know if they have cirrhosis, and you give excessive fluid or excessive plasma or excessive blood, you make them bleed more and they do worse. So that's the first principle. Now let's talk about the specifics. Are you going to measure a fibrinogen level? Well, if someone's bleeding seriously, you are going to measure the fibrinogen level because these patients are going to eventually use up their fibrinogen, which may be low at the best of times. So the next step is, once you're treating local problems locally and treating the shock, how do you interpret all these lab results? And I think that's the issue about cirrhosis. Let's look at them one by one. Platelets. A platelet count of 50,000 is enough to prevent massive bleeding. If you're bleeding terribly and your platelet count goes down to 20 and you've treated all the local problems, you're going to probably give some platelets if you're bleeding massively with a low platelet count. If you're bleeding terribly and your INR is 7, are you going to give plasma? Well, I think what you're going to do is this. You're going to use a massive transfusion protocol if the patient meets those criteria, which basically means they bled 3 or 4 units in the first hour and they're continuing to bleed heavily. That's the basic criteria for a massive transfusion protocol. You're going to follow it, and you will follow the INR, but you're mainly going to treat the protocol. Let me tell you what you will not do. You will not try to reduce the INR back to 2, because frankly, it's impossible. If you've got a patient with INR from cirrhosis, for example, or even from warfarin for that matter, and their INR is 2 or 2.5, and you give 4 units of plasma, you might return their INR to 1.5 and be of questionable value. So your INR is not your goal. It's treating the shock and the bleeding. Once you're engaged in a massive transfusion protocol, the patient continues to bleed heavily, and you've called the appropriate consultants in, and you've managed their shock, and you're preparing to do a gastroscopy. If you've done all of that, and you've treated locally, you're going to have to measure fibrinogen levels. And certainly in this case, if they're bleeding massively, and if fibrinogen level is less than 1 gram per liter, which by American standards is 100 milligram per deciliter, you're already going to give fibrinogen. Now, the Europeans use fibrinogen, the Canadians use cryoprecipitate. And in those states of heavy, massive bleeding, with a massive transfusion protocol in place, and a fibrinogen level under 1 gram per liter, you're going to give 10 units of cryoprecipitate or fibrinogen if available. I haven't yet talked about managing all these numbers in the absence of heavy, life-threatening bleeding. We may come to that.
All right, so just to review there a little bit, don't forget to order your fibrinogen level, because if they have less than 1 gram per liter or 100 milligrams per deciliter, then they need, in Canada, cryoprecipitate, and in the States, they need fibrinogen. When it comes to platelets, you really want to maintain the platelet count greater than 50,000 for active severe bleeding or CNS bleeding. You don't need to give platelets if it's more than 50,000 in general.
In the context of heavy, massive bleeding. In the absence of that context, you accept much lower levels.
All right. And what about PCCs and vitamin K and TXA for the liver patient?
So a certain number of patients with cirrhosis and high INR will be vitamin K deficient. And the figures I've read vary anywhere from 20% to the majority. So I'm not sure what the truth of it is. But certainly it is reasonable in a bleeding patient and even in a non-bleeding patient to give those patients with INR of more than 4, 5, 6, 7 vitamin K. Intravenously, possibly if they're bleeding heavily, and orally if they're not. That's perfectly rational and reasonable. In a small number of patients, it will help their INR, but probably not the majority. And of course, I want to emphasize so much. The INR is not the thing really to be followed, and you don't just use fresh frozen plasma to correct INR because it's not going to work, and it may actually be harmful. As a basic starting point, there's exceptions to everything I'm saying, obviously. But vitamin K, yep, that has a role, orally or IV, depending on the situation. And it may not reverse the INR if they're not vitamin K deficiency. If the INR is up because of cirrhosis and protein manufacturing problems, it's not going to change the INR.
So how do you sort out whether you're going to give vitamin K or not in the liver patient?
In a non-bleeding patient with cirrhosis who has an INR, let's say of 4, 5, 10, who is admitted to the hospital, who looks malnourished, which is most of them, I would think, I think giving vitamin K 1 milligram or 2 milligrams or 5 orally is reasonable. In the patient with an INR of 10, who's bleeding heavily, who's just arrived at the apartment, looks malnourished, I think it's reasonable to give vitamin K intravenously in that context. And there you're going to give probably 5 or 10 milligrams IV. Not really knowing if you're helping or not, but it would not be unreasonable at all because a certain portion will be vitamin K deficient. And there's no way to definitively test that out beforehand.
My understanding is that PCCs really don't have a role in liver patients.
We don't have a good answer to that. I would say, had you asked me that question 5, 6, 7 years ago, I would have said PCCs play no role in cirrhotics with a lot of bleeding because they don't correct the problem. I must say at the present time, there are some physicians who are beginning to use PCCs in this context, but this is not generally accepted, not that well studied at all.
Okay, so that's vitamin K, that's PCCs, platelets, cryo or fibrinogen. What about TXA? I mean, there was a while there we were giving TXA for everyone bleeding, and now the pendulum started to swing the other way, saying that actually there are thrombotic complications associated with TXA. For the liver patient who has a severe bleed, TXA or no TXA?
That's a great question. Well, a liver patient who's bleeding from their mouth, I might use oral TXA and swish it around. A patient with cirrhosis who has a nosebleed, I might use a nasal tampon with some TXA on it. But for an upper GI bleed and a patient with an INR of 5, 6, or 7, best current evidence is do not use the tranexamic acid. And the most recent study is the HALTED trial. Now, if you look at the trial of CRASH-2 in trauma and look at the old meta-analysis from the Cochrane group, the suggestion was that tranexamic acid did not promote thrombosis at all. And in CRASH-2, certainly it did not at all. And the suggestion was it may have caused slightly less blood loss. But the HALTED trial, which looked at the GI bleeding of tranexamic, was quite clear. Tranexamic acid did not prevent death. Tranexamic acid did not prevent death from bleeding. And tranexamic acid, to my own personal surprise, slightly increased thrombosis from, I think, about 0.5% to 1.5%. I was a bit surprised by the results, but the bottom line is I'm not going to be using tranexamic acid in patients with cirrhosis and GI bleeds. In fact, I'm probably not going to be using tranexamic acid in life-threatening GI bleeds at this present time.
It doesn't surprise me of the increased VTE risk with TXA. I do see patients coming in with VTE, not cirrhotics per se, and typically females who are given big doses of TXA for dysfunctional uterine bleeding, who have significant VTE and PE. And I always ask before I give TXA for ambulatory patients if they have a history of cardiovascular disease or more prone to strokes, or if they have a thrombotic state, I don't give it. And we've just talked about how cirrhotics may have a rebalanced hemostasis and are on the pro-coag side, the pro-thrombotic side. So I think all the more reason, as you guys just discussed, lay off TXA. No knee-jerk response in this situation.
Before we go on and ask Dr. Himmel about TEG and ROTEM, as of 10 a.m. on the day of the release of this podcast, November 10th, tickets for the 6th annual EM Cases course go on sale. Now, there's only 60 tickets available because we wanted to keep the conference highly interactive in small groups. And of course, this year it will be virtual, online, in small groups. So whether you're from Virginia or Melbourne or Sweden or Toronto, you can participate in the roundtable discussions with EM Cases guest experts on day 1 of the course, and also get into the simulations, ortho workshops, and ECG workshops on day 2 of the course. That's February 5th and 6th, 2021. So get your tickets at emergencymedicinecases.com/EM-cases-course before they sell out. Again, that's emergencymedicinecases.com/EM-cases-course. So Dr. Himmel, one thing we haven't talked about, which is very important in the very sick liver patient who's bleeding, is TEG and ROTEM. And a lot of the things that you've been saying up till now become much more simplified and much more nuanced and better treated if you do have TEG and ROTEM? Now, most of us don't have access to this, but could you just give us sort of a brief review of how TEG and ROTEM can help us in these kind of patients?
The TEG is a little handheld card on which you place some blood. And what it does is it follows your fibrin clot. So you put some blood on this little device. The blood begins to coagulate. You get platelets adhering. Then you get fibrin formed. And then the fibrin breaks down and you get fibrinolysis. And as the fibrin's being formed and as the fibrin's breaking down, it conducts electricity at different rates, and it can be picked up by this card. So you've got a card that retells you what's going on and answers the following question. Is a clot being formed? Is a clot breaking down? And if you know the information, you can give more specific therapy.
All right. So if you do have access to TEG or ROTEM, you should definitely use it to guide your management in the bleeding liver patient. If you don't, then you really need to be thinking about platelets separately. You need to understand what your INR level really means. You need to remember to order your fibrinogen level and then replace it if it's low. You need to understand that TXA is unlikely to benefit and may harm in patients with liver disease and GI bleeds in particular, and that PCCs are probably not going to benefit, and you should be probably consulting a hematologist if you're thinking about giving PCCs in a liver patient with a high INR. So we've established that liver patients are at high risk for thrombosis, and we know that liver patients with INRs of 5 or 7 can still develop portal vein thrombosis and other kinds of thrombosis. Dr. Himmel, is there any lab tests that can help us predict thrombosis in a liver patient? And please do not say D-dimer.
There's no simple test that can predict thrombosis. By and large, you've got to go on the patient's history, a physical, and then definitive testing to attempt to identify it. Now, we do know that the high INR and the thrombogenic problems are related to a failure of hepatic synthesis. And we do have a surrogate marker, actually a good marker for hepatic synthesis, many markers, but one of them is the albumin. So if the albumin is quite low, you've got a marker telling you that the coagulation factors are low, but you cannot predict in advance if your particular patient in front of you is going to be bleeding prone, thrombotic prone, or where they are in that entire scale. There's no simple measurement.
Okay, so suffice to say that if their albumin is very low, you might be a bit more worried about thrombosis.
Right, but by and large, if the albumin is low, you can be sure their INR will be low, unless there's a non-hepatic cause involved. So these things will travel together, and they're both warning signs to think carefully and liberate yourself from all your old understandings about INR.
Okay. Unfortunately, there's no well score for albumin in liver patients and thrombosis, but...
Not in the world of thrombosis.
All right. I want to talk a little bit more about portal vein thrombosis. It seems to be one of those diagnoses that's made after a patient's admitted to hospital for some other reason. Dr. Steinhart, can you paint a picture for us of the patient with portal vein thrombosis so that we at least have it on our radar when a liver patient presents to the ED?
Sure. So let's go back to anatomy class and recall the portal vein is formed by the confluence of the splenic and superior mesenteric veins that drain the spleen and the small intestine respectively. An occlusion of the portal vein by thrombus typically will occur in either cirrhotics and or patients who are in pro-thrombotic states. So the presentation, if not the long-term morbidity, mortality in this scenario, depends on whether the clot has extended back into other confluent splenic veins and the intestine. It depends on the specific etiology of the occlusion and where in the chronicity of development you catch it at ED presentation. Generally speaking, portal vein thrombosis is suspected in a cirrhotic with worsening ascites or any new decompensation that's not otherwise obvious at the bedside. So that's the big overview. Because up to a third portal vein thrombosis patients are asymptomatic And then another third presents with vague pain. And then another third presents with some form of GI bleeding. So not very specific. If there is fever involved and painful liver, then that's suggestive of a uncommon, but for real, a pyelophlebitis. This is a septic clot that forms in the portal vein. And the biochemical tests and other tests, really, the liver function tests do not help you here. They're only marginally increased, as are synthetic function tests like INR and albumin, because the hepatic artery circulation compensates for this. So you are right, in my experience, Dr. Himmel, that this is often found incidentally, typically on a CT, but you can find it on ultrasound. And how you approach it is more as an inpatient. You decide on multiple factors whether you're going to anticoagulate, but I dare say we don't initiate this in the ER. There are other things we have to consider, including are they bleeding from their varices, and weigh a lot of different things. That would be on the floor with the internist.
Suffice to say that portal vein thrombosis is a tough diagnosis to make in the emergency department, but we should think about it when we're sending patients off for a CT scan of the belly, asked to look for portal vein thrombosis if the radiologist doesn't know that the patient has liver disease, because that can definitely change the management of the patient down the road. Some of the clues, like you were saying, only about a third of them will have belly pain. About a third of them might present when they have a GI bleed. The symptomatology is highly variable, and their liver function is usually preserved. But it's something that we need to keep in our radar. And those patients that we're debating whether to get a CT of the abdomen or not, that have liver disease, we should probably have a fairly low threshold to get that CT, because many of them will have portal vein thrombosis that needs to be addressed.
Right. The worst scenario, of course, is that this causes a venous infarction of the mesentery, the intestines, either from immediate back pressure or retrograde propagation of the clot. And then, of course, nobody wants mesenteric infarction in anybody, let alone this compromised liver patient.
That's the biggest risk, of course. Most of the patients I've seen with portal vein thrombosis have been picked up coincidentally because they've had some mild abdominal pain and I've gotten the ultrasound. But certainly my threshold for ultrasounds in patients with liver disease who present with ascites or pain is quite low. I'll get much more than I used to. And certainly I do agree, ongoing pain for 24 hours in a complex patient or any severe pain up front, you need imaging for sure. The more you look, the more you'll see portal vein thrombosis. And a certain portion, as Brian suggested, will move up towards your liver, will occlude totally your superior mesenteric vein. And of course, you can even get a thrombosis of your hepatic vein where your entire liver drainage is interrupted. So these thrombotic problems are very real. I'm getting more imaging than I used to, I must say.
Let's throw a little wrench in here. So let's say you do get a CT scan or an ultrasound for a patient who has liver disease, who presents with some mild belly pain, let's say, and you get the report back and it says that there's a portal vein thrombosis there, and you get all his blood work back and you see that his INR is elevated at 3. He's not taking warfarin. You're assuming that his INR is elevated to 3 because of his liver disease. Does that patient require anticoagulation for his portal vein thrombosis? And for that matter, what if you diagnose PE in a liver patient and they have an INR of 3 because of their liver disease? Do you still treat them with a DOAC or with Coumadin?
Well, I must say, in Emerge, when I've treated all the other conditions and given antibiotics and stabilized the patient, if it's a small beta thrombosis in the portal vein, I'm not going to be an anticoagulant at that time. I'll leave that for a later discussion once the patient's been stabilized. On the other hand, if this portal vein thrombosis has at the point where the entire portal vein is thrombosed and involving also the superior mesenteric vein, now you're entering the world of acute mesenteric ischemia, superior mesenteric venous thrombosis subtype. Does that patient have to be anticoagulated? The bottom line is yes, they do actually. Exactly when you're going to do it, how you're going to do it, that has to be discussed. But they have to be anticoagulated. Otherwise, they're going to necrose off their entire gut and end up with major resection and surgery. As far as the PE question is concerned, no matter what the INR is, if you've got a pulmonary embolism and your diagnosis is an acute PE or acute DVT PE, these patients must be anticoagulated. Yes. Now the question is how you're going to do it. So yes, if they've got a thrombosis and it's clinically significant, they have to be anticoagulated. Otherwise, the thrombosis will spread and they'll have another one. Now, which anticoagulant do you tend to use? Well, you've got a couple options now. Most people will not use warfarin. The reason is quite simple. You can't follow the warfarin. You cannot follow the INR. Now, I've read that if your INR is normal, you can use warfarin. That's true. But most of these patients have INR of 2 or 3 or 4 or 5 or 6, so warfarin can't be used. Can you use intravenous unfractionated heparin? You can and you might if you're going to stop it, but it tends not to be done any longer because the thrombin time isn't as reliable. So we have 2 drugs we can use. Fractionated heparin, like dalteparin or enoxaparin, and these drugs are used all the time in patients with cirrhosis who have thrombotic conditions. These drugs are used prophylactically for admitted patients with cirrhosis, even if an INR is 2 or 3 or 4, because these patients are more prone to hospitalized acquired thrombosis than patients who haven't got this disease. So the answer until recently was low molecular heparin and the standard weight-adjusted dose. Now, there have been a few studies recently that are beginning to use DOACs, direct oral anticoagulants, and usually the anti-10 types, and most studies have been looking at rivaroxaban or Xarelto for treatment of DVT and PE in people with cirrhosis. So the answer is yes, you can use low molecular heparin, and yes, you can use rivaroxaban. I think at this very moment, most of the experiences with the fractionated low molecular weight heparin, Fragmin or dalteparin, primarily for DVT PE in people with cirrhosis and INRs of 2, 3, 4, 5.
All right. So then for portal vein thrombosis, you want to think about low molecular weight heparin and vitamin K as well, right?
Yep.
Okay.
Now, if you have a deathly ill patient with massive thrombosis and you're at an appropriate center that can do this, you're looking at some pretty interventionalistic approaches, like the interventional radiography, removing the clot in that manner. And also you're thinking about liver transplants at this point. And also you're considering in a patient who's about to die, a TIPS procedure, a portosystemic shunting in order to reverse some of the thrombotic tendencies. So when patients are that sick, they need some very sophisticated interventions. But certainly high NR is never a contraindication to anticoagulation in this context. Never in this context.
I think that's going to be a game changer for a lot of physicians out there. It's a little bit scary to think that you have a liver patient in front of you with an INR of 5 and they have a PE and you're still going to anticoagulate them. So that's a great pearl there. Now for our advertising segment brought to you by Metricade, the amazing scheduling system. Metricade can actually predict what the average physician to time assessment will be any given day by looking at the physician lineup. Some of my colleagues see 2 patients an hour, some see 3 or 4 or 5 patients an hour. If your group wants, Metricade will build the schedule based on this information as well as what shifts everyone prefers to work, creating a lineup that can handle the inflow of patients hour by hour. Best of all, the schedule still feels like self-scheduling rather than a performance algorithm. Let's move on to spontaneous bacterial peritonitis. Our liver patient that we presented at the top of the last podcast had a fever and belly pain. And of course, spontaneous bacterial peritonitis, SBP, needs to be on the differential for all liver patients with abdopain or fever. So let's get deeper into this. Unfortunately, there's no single test for SBP. So, Dr. Steinhart, how do you diagnose this sometimes challenging entity clinically?
So it can be challenging for sure. It can be subtle, especially in patients who have encephalopathy, or it can be overt. It's commonly end-stage liver disease where it presents with ascites, of course, mandatory. any new onset of fever, abdominal pain, any new onset of hepatoencephalopathy, as we mentioned earlier, metabolic acidosis, new renal failure, hypotension that can't be explained, hypothermia, leukocytosis, any other concern for an infection as part of this presentation warrants consideration for SBP, and then diagnostic paracentesis is the definitive procedure. Fever is the most common sign, and abdominal pain. We know because of the significant fluid accumulation that any organisms and suppurative response will not be as obvious because the parietal peritoneum isn't as irritated because of all the fluid. So you have to think about it in advance, you have to have an algorithm that includes SBP in patients who decompensate with liver disease. Don't be placated when you have a benign abdominal exam. At least 10-15% of patients with SBP have that situation and have proven culture positive fluid. So definitely a consideration, definitely a frequent presentation, definitely can be subtle presentation.
Okay, and in terms of the abdominal exam, we have lots of patients who come in who have liver disease and belly pain. Some of them will have pancreatitis, some of them will have cholangitis. There's a huge differential there. But generally speaking, do patients with spontaneous bacterial peritonitis, do they have impressive belly findings when you examine them?
Usually not. If you have impressive belly findings, specifically right upper quadrant tenderness, if not a really tender engorged liver, then we're talking alcoholic hepatitis in lieu of SBP. There are peritonitis causes that occur in everybody, not just alcoholic cirrhotics, that we have to be aware of. And so perforated diverticulum, perforated peptic ulcer, other things that can cause secondary bacterial peritonitis, you have to be on guard for. These can give you a more dramatic presentation, but don't expect guarding and rebound in anyone because of the buffering effect of all this acidic fluid. You have to go quickly to paracentesis. You should go on to a definitive imaging, and typically it's CT scanning if you're concerned about that. The latter presentations, we sometimes see fecal contaminant of the otherwise straw-colored acidic fluid that you tend to get. And so if you see fecal contaminant, you've got your diagnosis of a secondary problem, not a primary or spontaneous bacterial problem. So those are some considerations that we have to be aware of.
I must tell you a story. I saw a patient about 10 days ago who came in with severe abdominal pain. Heavy drinker. He'd had previous admissions for alcoholic intoxication and violent behavior. So he came in severe pain. He had rigidity and guarding. And I thought this guy had acute peritonitis and had ruptured a viscus. So, of course, I got a CT scan as quickly as possible. And this guy had no previous diagnosis of cirrhosis. So guess what his CT scan showed? Very significant ascites, which I was unable to detect clinically. And guess what his paracentesis showed? 1,000 neutrophils. So I think it's worth remembering people with SBP can have no pain, mild pain, moderate pain, and occasionally severe pain. Although most people with SBP have known established cirrhosis ascites, you might be the doctor to see them for their first presentation. And their first presentation of cirrhosis might be spontaneous bacterial peritonitis. How often have I seen that? Infrequently. In fact, I would say after 43 years, this was the first time I've seen it, or at least recognized it. And as far as your sensitivity for imaging, have a low threshold for imaging. If things don't quite seem exactly where you think they should be, low threshold for imaging.
Yeah, for both secondary causes of bacterial peritonitis and for portal vein thrombosis for that matter.
Sometimes you just can't tell.
Yeah.
And certainly if you are not going to image and the patient looks minimally ill and you've done a thoracentesis and treated and they aren't getting better, you keep them open mind, man. These are not the patients that you want to think too much before imaging. These patients are very vulnerable people, and they often hide their symptoms. So you've got to have a very open mind and realize there's a broad range of presentations.
So I'll relate a case recently of the opposite end of the spectrum to what Dr. Himmel just described. A patient with known end-stage liver disease, recurrent spontaneous bacterial peritonitis, comes in with a typical presentation. We go in and do a very clean, slick paracentesis, and out comes blood, pink, acidic fluid. And so we go back and discuss his history a little bit more and then go on to imaging. And of course, he had fallen the week previous, has had a subcapsular hematoma of his liver and bleeding into his peritoneum. So we were actually tapped a hemoperitoneum. So you can never drop your guard in these cases. They'll fool you.
The definitive diagnosis of bacterial peritonitis is made by tapping the belly and getting an acidic neutrophil count of more than 250. So I want to talk a little bit more about tapping the belly, about paracentesis in a liver patient with ascites. And this is a question for both Dr. Steinhart and Dr. Himmel. What tips and tricks, pros and pitfalls can you give us when it comes to tapping the belly of patients with ascites?
Have a low threshold for doing it. Determine if you want to do a diagnostic of their therapeutic tap. Absolutely use ultrasound. I would never do a tap anymore without using ultrasound. It's made me much more calm and peaceful about doing it, for sure. Are you going to get some blood tests first and look at the INR and the platelet count and so forth? Yeah, of course you are. Do you absolutely have to? Well, I guess not, but of course you are.
Is there an INR that's too high to safely do a paracentesis? And is there a platelet count below which is not safe to do a paracentesis?
I'm going to make a statement very akin with the statement about serum ammonia. There's tons of research on this, tons of articles. And Jenny Callum from Steinhart has written an entire chapter about interventions and INR and platelets. There is no INR and there is virtually no platelet count that is so abnormal that you cannot do a paracentesis. Virtually none.
So I'll second that with what I alluded to before, the Choosing Wisely Canada campaign. And I mentioned number one was never rely on a serum ammonia for HE, hepatic encephalopathy. Number two, for minor procedures, which paracentesis is in these patients, do not draw platelets and or INRs. They will not influence you going in or not going in.
INR is not a contraindication to a paracentesis, period. How about low platelets? Well, if the platelet count was 0 or 5 or 10, maybe. Certainly, I would be quite comfortable doing a paracentesis platelet counts down to 40, 30, 20, and it doesn't get much lower than that, actually. I would. Furthermore, when you give platelets, they might not even raise the platelet count. And how long after the pool of platelets are you going to do the paracentesis? I would say if your platelet count is more than 20, I'm going to do it. If your INR is under infinity, I'm going to do it. But a paracentesis, the most important thing is the ultrasound machine and your skill.
Ironically, some of our brethren are reluctant to undertake this procedure. I don't know why. It's typically like hitting the side of a barn with a snowball. They come in with a beach ball belly. This is so distended. This is in the patient who has recurrent accumulation of ascites and missed their appointment for outpatient ongoing maintenance paracentesis to debulk the fluid. And so they come in short of breath. They can't breathe, even sitting up or standing, and it's a massive ascites. So I do take fluid off these patients routinely. Some can argue that they're abusing the emergency department, but I think it's a fun procedure and they are so grateful. I'm not going to go through the exact procedures. You can find that on the web if you want to learn how to do that. But basically, aseptic technique, get all your equipment, including the vacuum bottles, lined up. Pick your site of puncture away from any caput medusae that are there, or away from the rectus sheath that inferiorly houses the big arteries that come up out of the pubic tubercle area. So you don't want to go too medial. I use extension tubing on my catheter once I'm in, because we're going to have to change bottles routinely, and I don't want to pull out or contaminate that area. So extension IV tubing we find very useful, and I typically don't go beyond 4 to 5 liters. They are grateful for any amount that is taken off. This is a stopgap measure that they know and we know will help them short term, but they will reaccumulate. I don't typically give albumin because I'm not going beyond 5 liters. And at the end of an hour and a half of taking the fluid off and the nurses having to exchange the vacuum bottles to collect this fluid, I think they're happy and I'm happy and the patient's happy to be discharged without waiting for blood bank to supply the albumin and infusing the albumin, et cetera. So that's what I do. I know others are quite dogmatic about giving albumin. There you go.
Yeah, I understand when it comes to giving albumin after removing more than 5 liters of acidic fluid, I understand that the literature is a little bit murky there. My reading is that if you suspect or they have spontaneous bacterial peritonitis and you take off 5 liters, then yes, give albumin. But if they're a patient that's just coming in to get the fluid taken off because they're uncomfortable, like the one you described, Dr. Steinhart, then an albumin generally is not indicated, or there's no evidence that it helps in that patient. Dr. Himmel, what's your take on the literature in terms of when to give albumin after a paracentesis?
Well, the guidelines are reasonably clear. I mean, they certainly say if you're taking off more than 5 liters, I can't remember last time I ever did that, you should give 8 grams per liter of acidic fluid removed of albumin if it's more than 5 liters. Under 5 liters, I tend not to. On a few occasions, I've used a pigtail catheter rather than an 18-gauge angiocatheter, an actual pigtail catheter, and boy, did I love that. That fluid came out. It was quite amazing and didn't block up either. So I did use a pigtail catheter with the extension tubing and a 3-way stopcock, and that was a beautiful experience. I never come in the midline. I always come in lateral to the rectus sheath. I always use the ultrasound machine. And one thing I've started doing recently is after I removed the catheter, the angiocath, I've been using Dermabond, 3, 4, 5, 6 layers of Dermabond. Now, it's a bit tricky because you've got to keep the area dry. So you're putting your finger on the hole and putting Dermabond on and putting your finger back on Dermabond. I find Dermabond, multiple layers, covered with a Tegaderm strip afterwards. It's been a very nice way of stopping that drip, 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 which often happens for hours afterwards. So I'm using more Dermabond, and I'm starting to use that pigtail catheter rather than an angiocath.
Some people talk about a Z pattern approach. So you pull the skin this way, you make your initial puncture into the abdominal wall, you pull the skin the other way, and you continue your puncture, and that way you get a zigzag track. So when you pull out, there's no direct track from the peritoneal cavity back to the outside, and therefore reduce any oozing.
All right, so a few tips and tricks there, trying a pigtail catheter and then using surgical glue like Dermabond or Swift Set are examples of surgical glue to prevent the dripping after, something to consider at least. Let's say you've now clinched the diagnosis of SBP, you've got your acidic fluid back and it shows neutrophils more than 250. This patient's going to get antibiotics and a few other things. Dr. Himmel, how do you treat SBP in the emergency department?
Certainly you give antibiotics, and certainly you give them early. I think 2 of the commonest choices are ceftriaxone and 2 grams, or cefotaxime. I think it's 2 grams every 6 to 8 hours. The bugs you worry about, generally speaking, are E. coli and Klebsiella, gram-negatives, and Enterococcus, rarely, and I suppose staph is also a problem potentially. But generally speaking, 3rd-generation cephalosporins. And they all get admitted to the hospital, of course, because they're going to be antibiotics for at least 5 days.
Okay, so that's the antibiotic part. What about albumin?
The guidelines from the American Association of Studying Liver Disease strongly suggests that in patients who are high-risk patients with low albumin, low body mass, higher creatinines, high INRs, more than 4 or 5 or 6, higher risk patients, giving albumin on day 1 and day 3. Day 1, 1.5 grams of albumin per kilogram, and day 3, 1 gram per kilogram is wise to do. If the patient is not considered high risk, their INR isn't 6 or 7 or 8, their MELD score isn't extremely high, you don't have to give albumin.
So when it comes to bacterial peritonitis, remember that liver patients are at risk for sepsis and dying from sepsis from any source. And bacterial peritonitis is one of those examples of that infection risk. Remember that the abdominal exam in SBP can be deceptively benign. Most of these patients require imaging to rule out a secondary cause of their bacterial peritonitis. When it comes to paracentesis, don't worry about the INR and don't worry about the platelet count unless it's under 20,000. It's safe to tap, and it's the only way to definitively make the diagnosis of bacterial peritonitis, namely a neutrophil count more than 250. If you do fill more than 5 liters of bottles with acidic fluid from your paracentesis, consider giving albumin. And if they do have bacterial peritonitis, then you're giving a 3rd-generation cephalosporin like 2 grams of cefotaxime or ceftriaxone. And you may want to also consider giving albumin at that point as well. So, in this podcast, we covered paracentesis, we covered spontaneous bacterial peritonitis, we covered portal vein thrombosis, the fine balance between thrombosis and bleeding, and how to manage those things in the liver patient. In terms of some key take-home points, I just want to review from the 2 podcasts that we've done. One is to have a low threshold to order acetaminophen levels in the sick liver patient, because a lot of these patients with acute liver failure can have acetaminophen toxicity, and we have a very good treatment for that is time dependent. Number 2, sepsis is a common trigger of acute liver failure and may be subtle, so when in doubt, treat on spec. Medications to avoid in liver patients, there's a pretty long list, but there's some key ones that are really important. Whenever possible, avoid NSAIDs, and if they're sick with hepatic encephalopathy, avoid benzos. Make sure you choose your antibiotics carefully. Macrolides and clavulin are ones that you might want to avoid. Watch out for hypoglycemia in these sick liver patients, and make sure that after you've corrected their hypoglycemia, that you continue an infusion that includes something like D10W after that hypoglycemia has been corrected. Do not assume that the liver patient with a high INR is anticoagulated. They are still at risk for thrombosis. Keep your differential wide in liver patients with belly pain and have a low threshold for abdominal imaging. And think specifically about the possibility of portal vein thrombosis and bacterial peritonitis, even in the patient with a benign abdomen. Remember that ammonia levels are unreliable and can even be misleading, so you need to assume high ammonia levels in the patient suspected of hepatic encephalopathy and treat with lactulose and or polyethylene glycol and rifaximin in the sick altered liver patient. Don't forget to order a fibrinogen level in the bleeding liver patient and give cryo or fibrinogen to keep that fibrinogen level above 100. And lastly, it is generally safe to perform a paracentesis in a liver patient with a super high INR, no matter what the INR is, and down to a platelet count of about 20,000. Do consider giving some albumin if you take off more than 5 liters, especially if you suspect that the patient has SBP. All right, so anything to add, Dr. Himmel, Dr. Steinhart, that we haven't covered yet about the liver patient, the future of managing liver patients?
Yeah, I wanted to briefly talk about alcoholic hepatitis, which I don't think we specifically talked about on entity by itself. So there are some patients who've had fatty livers and who are drinkers who will come in feeling unwell with abdominal pain and nausea, who will look extremely jaundiced. They'll have bilirubins of 40, 50, 60, 70, extremely jaundiced, and they'll have elevated AST and ALT, elevated enzymes, not in the tens of thousands, but they'll be elevated 5 to 10 times. So elevated enzymes up to 5 to 10 times elevated, a little confused, possibly, some abdominal pain, possibly, but definitely jaundiced. What do they have? Well, they probably have acute alcoholic hepatitis. Now, why is this an important condition? Because this condition, untreated, can progress rapidly to increasing liver failure and patients requiring a liver transplant. These patients are often treated with prednisolone for 28 days. So that's just another syndrome to keep in the back of your head.
Yeah, and they typically have a bigger, swollen liver that when you palpate it, they wince. It hurts. It's stretched. That capsule is stretched.
And these patients are complex. They have multiple social problems, and they need advocates, not just advocates for admission, not just advocates for social work, but also advocates for consideration of liver transplant. I'm going to transfer to a big center where they're going to get a TIPS procedure, because it's very easy to treat them, have them admitted, and they'll die in the hospital sometimes. There are centers where the patient might be better off, and you're often their best advocate. And if you know these things are all options, you can be an advocate. And sometimes even your consultants in your local hospital will be motivated when you bring up these topics, because it's very easy to write somebody off after their 20th admission to the hospital. It's an easy thing to do. And the treatments available today are amazing. Now, the outcomes aren't always great, but there's still lots of options that are not available at every hospital. So we have a massive opportunity to be tremendous patient advocates.
Love it. Patient advocacy is huge. Thank you very much, gentlemen. It's always a pleasure having you on EM Cases. It's just incredible, your wealth of knowledge and expertise.